That looks good, Dr. McCarty.
Good morning, everyone. Welcome to this week's Medicine Grand Rounds. Just a few reminders for those joining remotely. Make sure that your mics are muted today to avoid any unintended interruptions for our speaker. Please ensure your full name is on your Zoom login so you can be easily identified. And if you're logged in as a group, please email Department of Medicine Grand Rounds at hsc.wvu.edu to receive credit. If you have not participated and received credit for Grand Rounds via Zoom before, please complete the credit request form located in the chat box during the Zoom lecture. This ensures we have the appropriate information on file. We will save time for Q&A at the end, and if you type your question in the chat, I will work to relay those to our speaker. We will try to wrap up around 8:55 in order to get back to our clinical duties. Today, we welcome Dr. Devin McCarty. Dr. McCarty completed internal medicine residency here at West Virginia University in 2018 and also went on to complete his nephrology fellowship here in 2021. He has been serving as an assistant professor in our nephrology department. Prior to his medical education, Dr. McCarty served in the United States Marine Corps and Army National Guard. He has served in the Division of Military and Austere Medicine and Surgery while at WVU. Please join me in welcoming Dr. McCarty and thanking him for his service.
Thank you. Again, my name is Devin McCarty, and I'll be presenting combat kidney, the history of acute kidney injury, and renal replacement therapy in the deployed settings. Take me a second to figure out how to do this. All right. I have no financial disclosures. Our objectives for today is going to be an overview of the brief history of renal replacement therapy, describe the patient population and etiology of acute kidney injury in austere environments, overview the history of renal replacement therapy in the U.S. military deployed settings, overview examples of improvising renal replacement therapy in limited resource environments, and then finally, I'll introduce you guys to the Division of Military and Austere Medicine and Surgery. Objective 1 is brief history of renal replacement therapy, which will be abbreviated as RRT going forward in this presentation. 1854, Thomas Graham was widely thought to be the father of dialysis, first applied the term dialysis to the method of separating crystalloids and colloids based on their fusion through a gelatinous matter. This process of diffusion and osmosis became used in chemistry labs to separate dissolved substances. However, he was far ahead of his time, and this was never done clinically. In 1912, John Abel was the first one to conduct diffusive dialysis in animals using a glass tube filled with cellulose nitrate tubing and saline as a dialysate. This was presented at the 17th International Medical Congress in London, and apparently they loved it there. However, he was also still far ahead of his time and was never used for renal replacement. In 1924, George Haas was the first one to conduct hemodialysis for severe uremia. Unfortunately, it took too long, and therefore it was abandoned in 1928. The picture on the right here is an example of his dialysis machine. In 1937, William Elmer, ironically used cellophane tubing intended for hot dogs as the diffusion ultrafiltration membrane for renal replacement therapy on dogs that underwent bilateral nephrectomies. The picture here on the right is an illustration of the dialysis he used. In 1942, William Kolff invented the rotator drum dialyzer. He manufactured the dialyzer using parts of a Luftwaffe aircraft, which is the German aircraft machines. I was unable to find which aircraft it was that he used, but I assume it was the Stuka dry bombers. He also used a Ford Model T water pump and a sewing machine motor. And in 1945, it was used to treat an AKI on Maria Schaffhead. 1951, we have Captain Tishon, but I will discuss him a little bit later on, so I'll hold you in anticipation. In 1970s, University of Utah engineered a portable kidney that only weighed 17 kilograms and was used for ultrafiltration. They did not require a pump as it used a patient's own cardiac output for ultrafiltration through the venous pressure gradients. Surprisingly, there were no reported cases of dehydration. An example of it is pictured here on the right. In 1977, Peter Kramer used a form of renal replacement therapy called CAVH, or continuous arterial venous hemofiltration, much like what the University of Utah did for managing hypervolemia in critically ill patients. And in 1982, he introduced the use of normal saline as replacement fluid so it could be used for AKI patients. And again, here we have a picture of what it kind of looked like. Objective number 2 is the patient population and etiology of AKI in austere environments. There are 3 primary factors that contribute to an AKI in this population: the patient population, the nature of injury, and evacuation times. Those that could require renal replacement therapy in theaters are U.S. and allied military personnel, allied civilian and host nation civilian and military personnel. The picture here to the right was taken by me. It was after an extraction of a target we had from a time-sensitive targeting mission done in northern Iraq in 2009. The patient population is unique in the sense that the prevalence of the CKD differs among the different categories of personnel. U.S. and allied military have a low prevalence due to pre-enlistment and pre-deployment screenings. U.S. and allied civilian personnel have a lower than general population, but still slightly higher than the military personnel prevalence of CKD. And finally, the host and military civilian prevalence is closer to that of the general population worldwide. The nature of injury is divided into traumatic, non-traumatic, and post-traumatic. For non-traumatic causes, this is usually due to volume depletion, medications, poisoning, and infectious-related GN. Pictured here on the right is primarily what we lived on while conducting reconnaissance missions, which usually lasted 5 to 7 days outside the wire. The picture on the top is called Rip It, which is a very acidic energy drink, and handfuls of Motrin. Traumatic causes include direct kidney or GU trauma. Examples of these would be a gunshot wound, blast injuries, or falls. But these are rare due to protective gear. And picture here on the right is our example of our loadout, which you can see had armored plates that covered the chest, upper portion of the abdomen, the flank, and the back. Post-traumatic injury consisted of ischemia or hemorrhagic shock and crush injuries. To the right here is what we have called a regional support medic, as known as an 18 Delta, during a ragged edge training exercise. This was simulated to be an IED blast that caused an amputation and a compromised airway. AKI due to crush injury was first described in World War II during the London Blitz, and again in 1949 during the Italian campaign. Using a cohort of 33 antiuric non-mobile patients, mortality was high as 91%. After the introduction of renal replacement therapy in 1951, it was decreased to 53%. Pictured here on the right is a controlled IED blast after insurgent interdiction neutralization. Finally, the evacuation time plays a significant role. Factors that influence evacuation times are availability of transportation or lack thereof, patient stability, and presence of hostile forces. Average times during the Korean War was 4.6 hours, and after the introduction of Helo Medevac, it was drastically reduced to 30 to 35 minutes during the Vietnam War. Where I was located in northwestern parts of Iraq, our evacuation times were comparable to that of Vietnam. On the right here is a simulation of a patient evacuation time in the back of a simulated Boeing CH-47 Chinook, otherwise known as the Jolly Green Giant. Moving on to objective 3, I will describe the history of renal replacement therapy in the U.S. military deployed settings. Korean War, June 1950, North Korea invaded South Korea. The rapid advancement of North Korea was repelled back by the Americans and South Korean forces. It was then when the Chinese military joined the forces with the North Korean forces, and eventually in July of 1953, an armistice was declared, settling at the 38th parallel. Here we have the Korean experience. So during the start of the Korean War, deaths from AKI were similar to that of World War II, around 80 to 90%. In 1952, Captain Paul Teshan led the renal center at the 11th Evacuation Hospital of the 18th Army under the umbrella of the U.S. Army Institute of Surgical Research Team, abbreviated as USAISR. The wounded were transported to Battalion A stations, then medevac to Mobile Army Surgical Hospitals, otherwise known as MASH. And yes, that is just like the show that used to be playing. Of the 0.05% of patients that had oliguric AKI, overall mortality decreased from 90% to 53%. Patients requiring renal replacement therapy had a 70% mortality. On the right here is a picture of the dialysis machines that were actually a form of the 1940s rotor drum dialysis machines. Vietnam War. In 1959, JFK sent military advisors called MAGs, or Military Assistant Advisor Group, to Vietnam to help with infiltration of Communist North into Democratic South. In August of 1964, the Gulf of Tonkin incident, which was an alleged event, and where the North Vietnamese Navy attacked U.S. vessels, USS Maddox and USS Turner Joy, on 2 separate occasions. This led to Lyndon B. Johnson to send in thousands of U.S. Marines to Vietnam. An interesting fact here is the People's Army of Vietnam, also known as a PAVN, was first formed in 1944, consisting of 31 men and 3 women, only armed with revolvers. In 1966, the 629th Medical Detachment was established and appropriately dubbed the Renal Unit. Its final construction consisted of 11-bed ICU with nurses and corpsmen, which are Navy medics, trained in hemodialysis and peritoneal dialysis. They utilized the Tramadol standard twin coil artificial kidney, pictured here on the right. Now, this machine took 4 units of type-specific blood just to prime the machine. One of the first reported cases of combat casualties to survive a direct missile damage to the aorta with AKI was about a 29-year-old male paratrooper with multiple fragment wounds to the left chest and arm. He underwent several surgeries to include a left nephrectomy, a repair of an abdominal aorta laceration, and colonic perforations, all of which were complicated with sepsis. In total, he underwent 12 hemodialysis sessions with 51 units of type-specific blood. On October 25th, 1983, after a Marxist group called the People's Revolution Government and Cuban forces in Grenada arrested and executed the Prime Minister of Grenada, Maurice Bishop, joint U.S. forces and Caribbean forces invaded Grenada in an operation called Operation Urgent Fury. Here, the last military operation was conducted on November 1st. During this conflict, there was 1 soldier that was treated for an AKI at Walter Reed Army Medical Center. However, it is unclear if this patient underwent dialysis. In 1990, Saddam Hussein, in an unprovoked attack, invaded Kuwait, leading an international conflict. After 42 days of U.S.-led coalition attacks, former President George W. Bush declared a ceasefire on February 28, 1991. During this time, dialysis was available on a U.S. naval ship, Comfort, pictured here on the right. Dialysis here was mainly used to treat poisonings. But Not all U.S. military operations are conflict operations. On December 7th, 1988, northern Armenia suffered an earthquake with a magnitude of 9, causing the death of 50,000 to 100,000 civilians. Great Britain, Germany, and the U.S. supported the Soviet Union and Armenian dialysis teams. U.S. civilian nephrologists provided 18 to 35 dialysis treatments per day from December 18, 1988 to January 23, 1989. There were many lessons learned in the use of renal replacement therapy from this experience in austere environments. First, rapid resuscitation can reduce crush injury-related AKI. The dialysis teams must be self-sufficient to include machinery, supplies, and technical support. Expertise is required for water treatment for dialysis, electrical and plumbing support, and machinery maintenance. Proper communication with locals to ensure an efficient transportation of supplies, personnel, and patients. And finally, support for treatment teams and resupply routes. Picture here on the right is one of the buildings that collapsed. We moved more recently is Afghanistan and Iraq war in 2001 and 2021. A brief overview of the levels of care is you have a level 1, which focuses on life-saving actions by either a combat lifesaver or battalion A station. This is usually done at the point of injury. A level 2 is a forward surgical team, otherwise known as FST, where further resuscitative actions and damage control surgery are conducted. A level 3 is a subspecialty support with focus on trauma surgery, intensive care, evacuation out of theater, or back to duty. And then finally, level 4 is a general hospital medical center. And pictured to the right is myself behind a 240 Bravo after during an insurgent interdiction mission up in the mountains of Sinjar. As of December 2013, 51 individuals required renal replacement therapy. The patient demographics were as followed. They had a mean age of 26 plus or minus 6. 50 were males, 16% overall were Black, 67% were white. 88% of them had an AKI due to a blast or penetrating wounds, and 98% of them suffered an ATN, 72% which were due to rhabdo. 60-day mortality was 22%. Now, this is significantly less than previous reports from prior conflicts. Of the 40 survivors, 1 ended up with a diagnosis of ESRD, and the rest had an EGFR of greater than 60. For those that had an EGFR of greater than 60, none of them had any previously known CKD. On the right, there is Telfar, which is in the Nawab province of Iraq. The picture was taken out of a Black Hawk. Finally, objective number 4 is adapt and overcome the use of improvised renal replacement therapy in a limited resource environments. So the following are case reports of 4 patients that underwent improvised peritoneal dialysis in either Iraq or Afghanistan. Patient 1, we had a 9-year-old male with a single gunshot wound to the right iliac fossa and thigh. He had gangrene of the right leg and underwent laparotomy and hip amputation. Patient 2 is a 23-year-old with multiple gunshot wounds to the right arm and leg, a fractured pelvis, and bilateral renal contusions. Patient 3 is a 32-year-old male with cardiopulmonary arrest secondary to pneumonia. And finally, patient 4 is a 19-year-old male thrown from a moving truck. He had soft tissue injury, rupture of spleen and the liver, and also had abdominal compartment syndrome. All patients underwent improvised peritoneal dialysis at the level 3 facility. Due to lack of peritoneal dialysis catheters, also known as Tenkov catheters, JP drains were used as replacements. These were used in patients 1, 2, and 4. Patient 3 had a pediatric chest tube, which was used as a catheter instead. So for the outcomes, patient 1 was discharged on crutches with a serum creatinine of 1.28. Patient 2 was transferred to a local hospital. Unfortunately, he was lost to a follow-up. Patient 3 had complete renal, neurological, and pulmonary recovery. And unfortunately, patient reported died to cardiac arrest from hyperkalemia and acidosis. Another complication that requires improvising is the transportation of patients that require in-flight renal replacement therapy, or continuous renal replacement therapy. Here we have a 31-year-old male active duty service member that suffered an aneuritic AKI from rhabdomyolysis from a high voltage electrical shock. The USAISR burn team modified an HD next stage machine for in-flight use. The limitations here were the size of the machines and the weight of the bags in the machine itself. Pictured here on the right is them packing the patient up and putting him onto C-130. That same patient was transported from Singapore to Fort Sam Houston, Texas, where CVH was conducted for 15 hours of total 19.5 hours of flight time. The continuous renal replacement therapy was stopped only for takeoff and landing. In order to monitor the patient, point of care blood gases and electrolytes were tested via an iStat analyzer. The CVH was continued for a total of 51 days, at which point the patient recovered complete renal function. Pictured on the right is the next stage machine that was used. I actually had the privilege of meeting one of the in-flight nurses that actually helped conduct one of these, helped conduct this CRRT on this patient, which was the first time it was used. So this here is copied from the clinical practice guidelines of Joint Trauma Services, showing ways to improvise PD fluid when pre-made fluid is not readily available. Of course, I'm not going to go over all this because it'll take a while and it's kind of small to read, but this is available on the Joint Trauma Service website. There's a new one that's currently under review for revision, but that is not yet available for public viewing, but this was actually taken from that. We also do find ways to improvise solution for a CRRT. Here you can see a composition that this does not have any potassium in it. So of course this will be a 0K bath, but other options for this is the lactator ringer. Finally, objective 5 is the Division of Military and Austere Medicine and Surgery. So who we are, so first the core faculty consists of the heads of the department, Drs. Allison Wilson and Dr. Daniel Gerbeau, with other core faculty consisting of Dr. George Ball, Lieutenant Colonel Dr. Powell, myself, Dr. Linda Nild, retired Colonel William Black, Trudy Clark, retired Colonel Jerry Woods, and Lauren Walmsley. We're partnered with the Military Civilian Partnership, Military Health Systems, and American College of Surgeons Committee of Trauma, Special Operation Medics, and National Guard teams. Pictured in the bottom right-hand corner is Dr. Gerbeau discussing fresh tissue cadaver classes with the West Virginia National Guard TAG Brigadier General Crane. What we offer is 2 separate but conjoined programs with the medical student program, which consists of School of Medicine pipeline, medical student integration program, adjunct instructors, research support, and career development and family support. The career development program, which is geared towards active military members, consists of the special operations clinical training, the medical proficiency training, regional support medics, and the West Virginia National Guard. So I'll start with the career development pipeline. So you may notice students wearing all black scrubs with the logo on the left chest. These are students that are enrolled into the SOC-T or Special Operations Clinical Training course. This course is in relations with the Special Warfare Medical Group at Fort Bragg, North Carolina. We provide additional training that was not covered in their education, thus with a substantial amount of diversity. SOC-T was established in 2016 with either a 10-day or a 24-day rotation, with at least 252 medics students coming in through this pipeline. but however, that number has already since grown. This line is for 18 Deltas, which is the Military Occupational Skill or MOS code for U.S. Army Special Forces medical sergeants. They rotate through family medicine, dermatology, OBGYN, emergency medicine, pediatrics, dental, urgent care, opto nursing, the rapid response teams, trauma, and the neuro ICU. The 18 Deltas will have clinical cores, which are direct patient contact, practical and surgical skills in the SIMS labs, cadaver lab, a canine course and a large animal handling course. They also conduct casting and dental blocks and ultrasound handling. Their didactics consist of trauma and infections to the hands and face, hyperkalemia, rhabdomyolysis, shock, sepsis, and triage scenarios. We provide a pre and post knowledge test. This includes areas of trauma, ICU, ortho, anesthesia, pediatrics, OB, ID, derm, ENT, and opto. As you can see here, there's a clear improvement from their pre to post training. We also evaluate the students on their technical skills to include crikes, lateral canthotomies, needle decompressions, chest tube insertions, burn management, tourniquet placement and conversion, and hemorrhagic shock resuscitation. Here are just some pictures of fresh tissue reperfusion courses where hemorrhage control is taught with a realistic feedback. With the help of the School of Agriculture, there is a large animal module where students are taught to manage the health issues and safe management of both large animals and birds. That's German chicken, I believe. For those that have been with their units for an extended period of time, we also provide a kind of a refresher course, such as the medical proficiency training. These rotations are conducted for 2 weeks every 2 years or a 4-week course for every 4 years. This is in accordance with the U.S. Army Special Operations Command, and these courses are custom built rotations depending on the previous group's training, their area of operation, and what their long-term goals are. For the more advanced 18 Deltas, we operate that operate in a slightly more austere environment and have the need for prolonged evacuation periods. We provide a 9-week course, which ends in a 3-day cumulative exercise, also known as the CULEX, and certification of flight paramedic. I had the opportunity to observe this training here and also down in North Carolina, and I can personally tell you it is a very extensive and exhaustive training program. We not only provide education for the special operation medics, but for also the National Guard. This is a 5-day curriculum with participants consisting of APPs, MDDOs, nurses, and medics. This is more targeted towards the training with simulations and triage scenarios. And this course also ends in a cumulative exercise in the perfused cadaver lab. Switching gears a little bit, I'm going to move over to the medical student program. Here we have 2 programs, Special Operations Medical Pipeline, which is known as SOMP, and the Special Operations Medical Student Integration Program. The School of Medicine and Pipeline, here we help identify barriers to eligibility, processes and preparations, identify flaws in the screening rubric, giving those that served us an opportunity to an equal and fair screening process. We also offer help to guide the applicants through their admission committee. All of these applicants are manually reviewed and see our School of Medicine diversity policy. Currently, we have students from the 18 Delta and SYDC, which is the Special Operations Independent Duty Corpsmen, which come from the Navy. They can apply up to 4 years before their anticipated start date, and of course, it's free. They have access to a dedicated admissions counselor, MCAT prep material, assistance with their application, mock interviews, and shadowing opportunities. So far, we had 13 medics with 100% success rate, and there is 42 more to come. Applicants. The picture on the right is the group that's here currently. The Medical Student Integration Program, we offer a mentor-mentee program, research opportunities, which we have them develop a project in the first year and try to complete it in the second year. They're also able to participate in updating the clinical practice guidelines and the journal, which is the Journal of Special Operations Medicine reviewers. They also have an opportunity to be an adjunct instructor with CCTI, given these military courses, given the fact that they've done this prior to coming in here. But also, we need to take care of the family as well. So we offer support, staying well connected to the families and everyone involved. This was, I believe, at the last Christmas party. Our future endeavors here is to align critical task criteria with the Joint Special Operations Medical Training, otherwise known as the schoolhouse. We're trying to establish a center of excellence for military medical training, and of course, maintain a steady stream of the SOM Medical Student Integration Program. So it was a lot faster than I thought it would be, much faster. But I want to give a special thank you to Dr. Allison Wilson, Dr. Daniel Gabro, and Lieutenant Colonel Ian Stewart, MD. For my references, if you care to look. And I guess I have plenty of time for questions. I went through that a lot faster than I would.
There's a question in the chat from Dr. Moss. It says, Devin, thank you for the presentation. What is current thinking about early versus as indicated intervention for anuric AKI after trauma?
So we technically, if they're anuric at the level 3 facility, we pretty much kind of do an early start on them, mainly just to stabilize them and have them on CRT. Once they get to the level 4 facility, then they're in a more of a medical center and where they can be assessed for renal recovery. But in the early stages, we're getting more towards early start.
We have another question in the chat. It says, does supplementation increase AKI?
By that, I assume you're talking about when you're like working out supplementations. If this is the case, not necessarily, unless it's the issue with soldiers downrange is that they are quite frequently on the dry side and dehydrated. So if they're taking these supplementations, obviously steroids can cause a host of renal patients like FSGS, but they do test for those downrange. So, but other supplementations like creatine, proteins, not really, but it's mainly because of dehydration and a lot of ibuprofen.
We have another question from Dr. Badami. Hey, Devin, thanks for the talk. Is PD generally the preferred method in these settings, even with abdominal injuries?
So it's mainly dependent on what we have down range, but we have proved that even with abdominal injuries, you can still conduct peritoneal dialysis. Typically, it's if they don't, we they would prefer CRT, but if they don't have the machines, then they'll have to opt for PD or just rapid evacuation to a level 4 facility.
Another question from Dr. Schmidt. Devin, thank you for your service and thank you for the great presentation. How might we leverage this field experience here in rural West Virginia during these times of need for emergent dialysis away from approved hospital settings?
So that's a great question. Right now, we're having an issue with our availability of some of our 4K fluid that we have, the Prismasate. So able to use improvised fluids would be an option. And then even for more of the rural areas, having improvised peritoneal dialysis, which would be an excellent way to help stabilize somebody so they can get to a higher level facility.
Dr. Lickholm says, thank you for your interesting presentation. What an inspiring program, especially including the medical students. What do you find most challenging about treating these patients? Are there champions in Congress for your program? Also, thank you for your service.
Well, thank you. For treating these patients, the most challenging portion is it specifically, now without going into too much detail, is actually the evacuation time. There's gearing more towards what they call PFC, which is prolonged field care. And in that setting, these are typically the special forces sergeants who may not be equipped to handle such, peritoneal dialysis or CRT. So that's probably the most challenging, is getting them to a facility that can have these availabilities to renal replacement therapy. Do we have champions in Congress? We do. I just, as of right now, can't really comment on that. But yes, we do have. I guess I could say maybe Senator Manchin is one of our congressmen that are actually advocating for this program and to see it grow.
Dr. Moss says, do you have acute peritoneal dialysis trocars as part of your field kits?
So when we talk about field kits, there's 3 different types of bags. One is called the IFAC, which is an individual first aid kit, which is a very bare minimum kit that doesn't really have much of anything except stopping bleeds and securing airways. Then there's an aid bag, which will have chest tubes availability to trachs. And then there's a truck kit, which is a little bit larger, but none of these have dialysis trocars, mainly because this is more of a level 1, level 2 kind of care, more of the case outside the scope of the actual medics. Once they get to level 3 facility, then they'll have, if they have dialysis, not necessarily having trocars, but they kind of do an open abdomen to get into the peritoneal space.
All right, thank you, Dr. McCarty.
Thank you.